So, what are functional or non-epileptiform seizures?
So functional seizures, we don't call them functional seizures anymore. Now we call them non-epileptiform seizures. And the criteria for this non-epileptiform seizures is that these are seizures basically, motor fits, motor convulsions, in which there is no abnormal discharge from the brain cells. Normally, we know, in any seizure, we define it that there is an abnormal, sort of a discharge from the brain cells. But in these non-epileptiform seizures or functional seizures or conversion syndrome or whatever name you want to give them, there is no abnormal discharge from the brain cells.
What are the causes of non-epileptiform seizures?
Good question. Why it occurs? Well, there has been a lot of research on this subject. Why it occurs? There have been many theories because in most of these cases, we have seen that there are no underlying structural problems, like the brain is not shrunken or enlarged, or there is some form of mass inside the brain. But we have seen that there are a few predisposing or risk factors. So it usually happens in those children in which there is something in the past, like is usually a stressful past, or they have been suffering from post traumatic stress disorder, or they might have been bullied, or there might have been some, sort of weaknesses in their personality, or somehow they are not able to express them like the way other people usually express them in the form of, let's say, if somebody gets upset, they can be, they can have rageful behavior, or they can be mean to others. So it's not that sort of thing. These people, they say, have got something related to their social history. So it's very important that you probe the social history. So there are a few of these risk factors which can predispose a child to non-epileptic form seizures. Scientifically, they say that there is some form of, abnormal communication between the frontal cortex and those areas of the brain which are related with your emotions, like the cingula and the amygdala. And somehow the way that these, sort of connections, reciprocal connections between the emotion centers and the motor cortex, the frontal cortex, that work doesn't work in these individuals. So sometimes, like certain types of functional MRIs, they can pick up like some form of abnormal metabolism in certain areas of the brain. But by and large, there is no structural issue with these children.
How does it present and how is it diagnosed?
Yeah, so usually these types of seizures, these non-epileptiform seizures, they are more common in teenagers. You would rarely see these seizures to occur in somebody who's younger than 8 years of age. And usually, if you see, these are very bizarre seizures. Like if somebody who has been observing children who have got epileptiform seizures, these are quite different. So these are quite bizarre. You will see there is an element of pelvic thrusting or very bizarre jerky movements of the whole body. So you will see most of these children, they've got their eyes closed, while in real seizure, you might see that the eyes are open, have been rolled back. So eyes are mostly closed, and if you try to open them up, you would see there is an active opposition to, in like, if you are trying to attempt to open them. And usually, even if you look at the characteristic of these jerks, they are very asynchronous, like non-rhythmic. It would be flailing of the or tremulous limb movements. That can again vary between the attacks. It's not like they would be, sort of showing a uniform jerky movements between different types of attack. Every time there would be different. So sometimes they go slow, sometimes they become more active. Depends. And you will see that these seizures are, they become more in intensity if people are there. So it usually happens, it's quite witnessed, because it usually occurs in those surroundings in which there is presence of the people. Rarely it would occur in a condition in which the child is alone. So you will see that this usually occurs when people are around them. And this type of motor activity, this non-epileptic motor activity, this can stop and start during the spell. They sometimes might be weeping and crying during the seizure or after the seizure. And one characteristic thing is that, like, these are usually prolonged seizures, but still in that prolonged seizure, there is usually no injury. I would say any child who has got a seizure lasting more than 5 minutes, there are 20 times more chances that it might be a non-epileptiform seizure. I'm not saying that epileptiform seizures, they do not be prolonged more than 5 minutes, but the chances of being non-epileptiform just increases if the seizure increases more than 5 minutes in duration. The other thing is that these seizures can sometimes be precipitated by what we call a suggestion as well. If you try to suggest, like for example, one thing that can be done is if you take a tuning fork, let's say if the seizures has terminated, the child is in front of you, and you just like touch and say, I'm going to touch this on the side of the temple, and as soon as I touch it, you're going to have a seizure in the next say a few seconds or minutes, and you will see that if you do that, in most of the cases, in a few seconds to a few minutes, the child would start having these bizarre seizures. So this suggestion sort of thing can also bring about seizures in a non-epileptiform seizure. So as I told you earlier, that usually they are longer than 5 minutes in duration. Some I've seen children where they've been seizing for 2.5 hours, and if somebody has got a 2.5 hours of epileptiform seizures, they would be in a very bad condition. But usually, if you see if these seizures are occurring and you attach the child to the monitors, you will see that most of the time the vitals are quite stable. I mean, even despite that the child is actively having jerky movements of the body, you will still see that the heart rate is fine. There's no tachycardia. There is no drop in saturations. The respiratory rate is fine. Our blood pressure is fine, and even if you do, let's say, serum lactate levels or prolactin levels, like after the seizure has stopped, you'll see that most of the time they would be quite in the normal range. So that's like another indicator that this was a non-epileptiform seizures. So most of the time that these seizures, they would occur in a crowded place. Um, Usually, or sometimes they can be brought about by hyperventilation as well. There might be an anxiety or a panic attack before the child actually goes into a non-epileptiform seizures, and then, as I told you, that they are usually prolonged.
How is it treated?
Now, as far as treatment is concerned, I've seen that many of the children with non-epileptiform seizures, they have been treated with, as you would treat an active epileptiform seizures, giving them benzodiazepines, and you'll see that usually it flattens them, but still the seizures, they do not stop. So they can go into they can go into respiratory depression. I've seen that kids have been even intubated with non-epileptiform seizures. It's very important that you recognize the difference between an epileptiform and a non-epileptiform seizure, because these kids, they do not require any treatment. The best you can do is, like, more people, if they are surrounding them while they are actively seizing and you are attaching monitors, you'll see that the seizures will not stop. If you just attach the monitors and you see that these vitals are stable, it's better that everybody leaves them. If you leave them alone, you'll see that the seizure stops quickly, as compared to if you are just standing and monitoring them from a very close distance. So usually it's recommended that you leave them alone. If you leave them alone, the seizure would quickly stop. And as soon as the seizure stop, you'll see that, like, they are back to normal. I mean, they might be weeping, they might be crying, or they might be, they might be back to their normal self. So usually there is no post-ictal period. So the thing is that usually they're not treated by active, active, sort of administration of benzodiazepines, or giving them like other anti-epileptic medications, because that doesn't help in these cases. So most of the time, if somebody is on, let's say, uh, anti-epileptic medications, and they are not responding to the treatment, so one of the possibility where you can think of, like, certain types of resistant epilepsies, or sort of issues with the compliance of the treatment, also keep the possibility of non-epileptiform seizures. Because another, we have seen there is another possibility. Some kids who have got epileptiform seizures can have non-epileptiform seizures as well. It's not like they are two separate entities, either epileptiform or non-epileptiform. Sometimes you might see that a child has got both. He's got epileptiform seizures and non-epileptiform seizures, but you will see that the characteristics of the epileptiform and the non-epileptiform seizures in the same child would be different. Epileptiform seizures are brief. They are usually associated with autonomic changes. The child may have frothing from the mouth. They might be incontinent. They're usually not that long lasting, and associated with tachycardia, uh, usually drop in saturations, sometimes apneic spells as well. While these types of seizures are quite bizarre, they're quite prolonged and usually associated with normal vital signs. So treatment wise is important. While the epileptiform seizure, you will go through your normal drills that you would do. Like, for example, if it's not like, if it hasn't responded after 5 minutes, maybe you start with buccal midazolam or rectal diazepam or IV lorazepam, depending on the situation and the protocols. But if it is a non-epileptiform seizure, then usually they have to be put in a sort of a safe position, and you just wait till the seizure they stop. Honestly, I mean, whether it stops in 10 minutes, whether it stops in 2 hours, you just have to make sure that the child is safe. There is no other treatment, and usually if you leave them alone, provided that you know that they are in a safe environment, that's it. It would stop quickly, as compared to if you are like, a bunch of people standing on that, appearing worried and trying to figure out what's going on, so the seizure would last longer. Nevertheless, they should be under the care of a neurologist, because you never know if a non-epileptiform seizures could somehow evolve into epileptiform seizures at some point in time, or an epileptiform seizure child can have non-epileptiform seizures. So it's very difficult to predict. Again, as I told you, that it's very important to delve into this, into the past social history, because those people who've got risk factors, they're more likely to have these non-epileptiform seizures. Yeah, so the takeaway points is that non-epileptiform seizures are more common in teenagers. They usually have got something in their past social history, or they might have personality, excuse me, they might have personality problems. These seizures, non-epileptiform, they usually last long. It's usually associated with normal vital signs while the child is having seizing, or while the child is having seizures, and no treatment works in that. You usually need to leave them till the seizure stops. And they should be under the care of neurologists. It's a diagnosis of exclusion. So you still need to rule out the epileptiform seizures. The best way of doing that is like to do a video EEG. And usually in these seizures, if you are lucky enough to do a video EEG, you will see that the brain discharges are normal. There are no abnormal waveforms on the EEG. So that's another like clue. So it's a diagnosis of exclusion.